لا لا لا.
بسم الله الرحمن الرحيم. أنا برحب بيكم كلكم. أنا دكتور هيثم بدران، أستاذ القلب في عين شمس والبريزيدنت اوف ذا إكرا للدورة دي، وبرحب بكل الشير بيرسونز اللي معايا، دكتور يحيى من السعودية، دكتور وجدي، دكتور سمير، دكتورة ميرفت. وإتس ماي بليجر يعني تو ستارت الإكرا 2023. we hope إن ده يبقى يعني a beginning of a series of events بعد كده sponsored by the ICRA. عشان يعني for the electrophysiology in Egypt يعني and in the region to have something يعني new in the next era. الحقيقة I will start with the first session for the sake of the time. احنا هنتكلم the first session the AF session toward higher long-term success in AF ablation. I will start with the first speaker, Professor Ahmed Nabil, my friend and colleague from Ain Shams University. He will talk about the patient selection and adjusting modifiable factors in atrial fibrillation.
بسم الله الرحمن الرحيم. شكرا دكتور هيثم، بشكره على مجهوداته، واتمنى ان شاء الله انه على ايديه هتبقى في انشطه احسن وننهض بانشطه الشعب ان شاء الله. احنا هنتكلم على atrial fibrillation. We all know that the atrial fibrillation one of the most common arrhythmia, where it has many global prevalence arising due to the increase in the aging world population. Very important to know that atrial fibrillation increases many cardiovascular outcomes, adverse cardiovascular outcomes. But what is important and I want to stress on is the depression. Which is reaches up to 16 to 20% of patients. Even sometimes some patients may tend to have suicidal ideas, and impairment of quality of life increases up to more than 60% of patients. But on the other hand, atrial fibrillation ablation is a well-established treatment for prevention of AF recurrence, and when performed by appropriately trained operators, it could be safe and more superior to antiarrhythmic drugs for maintenance of sinus rhythm. And with all the increased technologies and all the options that are offered by the companies, atrial fibrillation ablation can be a first choice treatment in many patients. In the structured characterization of atrial fibrillation, the recent guidelines in 2020, with the 4S system included the symptom severity, which is very important in characterization of the patient and assessment of the patient. And it is important for us to know whether the patient is symptomatic or not, because a highly symptomatic patient is an indication and could take the way for AF ablation. Also, the severity of AF burden, either whether it is paroxysmal pattern of atrial fibrillation or persistent pattern, and the total AF burden is an important factor in assessment of patient and deciding whether to ablate AF or not. And of course, the substrate severity, and this is of course related to the comorbidities and the cardiovascular risk factors that the patient has. We all know the guidelines, and we all know that AF ablation is an alternative to antiarrhythmic drug if one antiarrhythmic drug failed to control the symptoms of a patient in patients who are either paroxysmal atrial fibrillation or persistent atrial fibrillation, whether they have major risk factors for AF recurrence or not. What are the major risk factors for AF recurrence? It is the significantly enlarged left atrium, the advanced age, long AF duration, renal dysfunction, and other cardiovascular risk factors. So any patient, even if he has a persistent atrial fibrillation with those major risk factors, they are indicated for AF ablation if medical treatment failed. And this takes a class 1 indication with a level of evidence B. Even with the major risk factors for AF recurrence, it is indicated with a level of evidence, class 1 level of evidence B. And at the same time, atrial fibrillation as a first-line therapy is indicated in paroxysmal atrial fibrillation who are highly symptomatic after considering, of course, the patient choice and the benefits and risk of the procedure. But it takes class 2B, a lower level of evidence in patients with persistent atrial fibrillation. But it came to take class 1 in patients who have tachycardia-induced cardiomyopathy. So AF catheter ablation is indicated as a first-line therapy with class 1 indication in patients who have tachycardia-induced cardiomyopathy. And it took class 2A indication in selected patients with reduced ejection fraction, and we will talk it in details about patients with heart failure. So it is indicated in patients with heart failure, but the guidelines or the statements at that time did not specify what are the criteria of patients who have heart failure and atrial fibrillation, what are the criteria for ablating atrial fibrillation. And of course, they recommended that we should take in consideration the procedural risk, the major risk factors, and discuss these issues with the patient himself. This is the algorithm that shows that atrial fibrillation as an alternative for antiarrhythmic drug is indicated for paroxysmal atrial fibrillation, persistent atrial fibrillation, with or without major risk factors. Okay, we should identify, we should know who are the patients who are less likely to benefit from AF ablation, or that they have a less outcome or not a high benefit from AF ablation. Of course, the persistent and long-standing persistent atrial fibrillation, left atrial dilatation, patients who have extensive atrial scarring or fibrosis, they of course have a less outcome or a poorer outcome. Structural heart disease like hypertrophic cardiomyopathy, there is increase in the atrial wall thickness, which may limit the effectiveness of ablation. And of course, the valvular heart disease, because the hemodynamic forces causes more electrical remodeling and more structural remodeling, so it reduces the success of maintaining sinus rhythm. Some group of patients, they have, yes, they can benefit from ablation, but they have higher risk of procedural complications, like older patients, like patients with heart failure, like patients who have higher risk of ischemic stroke. And there is a question about the genetic susceptibility, if there is a factor or a genetic factor that can impact the success of AF ablation. There are many prediction models that were published that can predict what is the potential benefit or the risk of AF ablation, and what is the probability of success of atrial fibrillation, like the Apple score, like the CAP AF score, like the Atlas score. All these scores try to predict who are the patients who will benefit more from AF ablation, but all the models did not precisely determine a clear criteria for the patients with no impact on the guidelines, for example, or no impact on the criteria or statements by the European or by the American Heart Association. Regarding heart failure, the indication for AF ablation in heart failure depended on two famous trials, which are the CASTLE-AF trial and the ATTACK trial. The CASTLE-AF was done in 179 patients for catheter ablation versus conventional treatment in 184 patients. And they found that AF ablation was associated with decrease in the composite endpoint of mortality and morbidity and hospitalization for heart failure. And this was mainly derived by the decrease in the total AF burden on those patients. So they had less AF episodes, which was positively reflected on the heart failure symptoms, so they had less hospitalization rates. Also in the ATTACK trial, which was done in 102 patients for catheter ablation versus 101 for medical treatment in the form of amiodarone, they had improvement in the ejection fraction, they had improvement in the 6-minute walk test, they had improvement in the Minnesota Living in Heart Failure questionnaire, and all these impacts was derived through improvement of the AF burden. So it was a matter of benefit in the morbidity and the mortality, and not regarding the symptoms, but this indication was derived by improvement in the mortality and the composite of cardiovascular death and hospitalization. So we did not have any clues or any strict ideas which heart failure patient can we ablate for AF ablation. But some data from CASTLE-AF trial showed that patients with NYHA class 1 or 2 and patients with non-ischemic etiology and patients who had early atrial fibrillation can have better outcome. On the other side, enlarged atrium or evidence of atrial myopathy or atrial scarring, if shown by cardiac MRI, and the presence of LV scar if a patient had ischemic myopathy, these were a bit having poorer outcome. Another statement in the guidelines into 2020 stated that weight loss is recommended in obese patients. And this takes us to the very important matter of adjusting modifiable factors, because we have many risk factors that contribute for the formation of abnormal substrate in atrial fibrillation, like hypertension, like diabetes, like physical inactivity, like dyslipidemia, like smoking, like alcohol. All these factors contribute for formation of abnormal substrate for AF and results in poorer outcome with rhythm control strategies, either by antiarrhythmic drugs or by catheter ablation. Because all these factors can increase the left atrial fibrosis, increase the structural remodeling, increase the inflammatory markers, causes electrical changes at the cellular level. So it causes structural changes, structural remodeling, and electrical remodeling. And the adjustment of these risk factors are very important, either in increasing, either for decreasing the atrial fibrillation burden in patients medically treated, or even after AFib ablation, the risk factor modification can increase the success of ablation outcome. So it can be beneficial before the ablation and also after ablation. And these are many trials that showed the beneficial interventions that caused better outcome in AF burden, controlling the blood pressure, controlling the weight loss, controlling the alcohol use, obstructive sleep apnea. All these trials showed better AF burden with control of these risk factors. So what are the goals? I want the diabetes to be less than, the hemoglobin A1C to be less than 7, blood pressure not more than 140/90, optimizing the body mass index, treating obstructive sleep apnea with CPAP. And we showed a study here in 2014 that showed that AF ablation catheter, the outcomes were better in patients who were involved in a program specified for risk factor management, with a better AF survival after a single procedure or even multiple procedures. So in conclusion, ablation improves quality of life in patients with symptomatic AF. Proper selection of patients for AF is crucial to increase the success rate, and we need to know who are the patients who have a poorer outcome to increase, to decrease the risk and increase the AF ablation success rates. AF ablation is indicated after failure of drug therapy in paroxysmal and persistent atrial fibrillation, and it is indicated as a first-line therapy in selected patients with paroxysmal atrial fibrillation and also in tachycardia-induced cardiomyopathy. Older patients, longer AF duration, larger left atrial size, and renal dysfunctions are all factors predicting worse outcome for AF ablation, and identifying patients who are less likely to benefit from AF ablation can highlight areas in which future research might lead to better AF outcomes. And adjusting modifiable risk factors are important in deciding which patient we can need for AF ablation, and also it can increase the success rate in patients who already had AF ablation if specified programs were followed. Thank you very much.
I see many patients with AF, but I did not refer for ablation because most of them are having multiple risk factors for recurrence.
Yes, sometimes we see obese patients, sometimes we see patients with obstructive sleep apnea. We can't refer this patient for AF ablation before we properly manage these risk factors. And if these risk factors are adjusted and are treated properly, and then the patient still has AF, then we can do AF ablation.
شكرا نبيل على المحاضرة very elegant يعني. بالنسبة للموديفايد ريسك فاكتور اللي الدكتور سمير بيقول عليها، أعتقد كل الستاديز المعمولة أهم حاجة فيهم اللي هي بتليد تو مور ستراكشر موديلنج والكتريكال موديلنج هو العيانين هايبرتنسيف، لأن بيبقى ليه امباكت على الليفت اتريوم، فبالتالي بيبقى فيه اريا اوف فايبروز ودايلاتيشن، فده من أهم الحاجات. الحاجة الثانية برضك المهمة قوي هي الأوبيزيتي، لأن هم حتى كلاسيفايد الأوبيزيتي على جريدز ال 25 وال 30 وفوق ال 30، وكل واحد فيهم ليهم ريسك معين. ومجرد ان انت تقلل ال 5 يونت من البودي ماس اندكس ده ليه امباكت ان مثلا 20 او اكثر من 20% من الناس اللي لقيتها في البيشن عندهم فيري لونج اريزميا في سرفايفل. فدول من الحاجات المهمه طبعا، والسليب ابنيا والانكتيف دول مهمين. الحاجه الثانيه اللي عايز اقولها هو ان الناس الهارت فيلير انت قلت ان السلكشن بيبقى على النون اسكيميك، وده بالنسبه لي غريب، لان الاسكيميك على الاقل فيه سكار لوكالايزد اكوردنج للديستريبيوشن بتاع الفيسل، انما النون اسكيميك ده هيتروجينس والسبستريت از فيري هيتروجينس. يمكن استخدام السكار بيردن بالجادولينيوم والام ار اي يمكن ساعدت، بس برضه انا مستغرب الاسكيميك كل الناس بتعمل اسكيميك ويعني وفي سكسس ريت مش بطال، انما النون اسكيميك دي في رايي فيها شويه يعني مش قادر افهمها اشمعنى يعني.
يمكن حضرتك موضوع ال بي سكار والليس امبروفمنت انجكشن فراكشن في الاسكيميك بيشنتس اللي عندهم سكار، فبيقلل شويه الامبروفمنت في الايجكشن فراكشن. لقوا انه في النون اسكيميك عشان ما فيش ويل فورمد سكار فممكن يكون الامبروفمنت احسن شويه، قد يكون ده.
Thank you very much, Doctor, for this an excellent presentation. I have two questions for you. The first one, what do you do for obese people with the different modality of treatment now for obesity? What's your recommendation for them? Second, which patient you would screen for obstructive sleep apnea, whether with the full sleep study or overnight pulse oximeter?
Well, the patients with obesity, they should be properly treated by control of diet. We should monitor the body mass index. The waist to hip circumference is very important, and we can refer him to a specialized physician for this matter. And whenever the obesity is improved and the body mass index improved, so I can think or just start to think whether to do AF ablation or not. This is regarding the obesity.
Regarding obesity, Ahmed Samir in Austria, he's Egyptian now in Austria leader, consultant electrophysiology. Ahmed, you told me once that you refuse patients with body mass index more than 30.
30, yes.
I refuse patients obese to go for ablation. I said go do bariatric surgery, and I have one patient for whom I did ablation and was unsuccessful. And then after a few years, he was out of the lab, failure of DC shock, failure of ablation. And then after a few years, and he was a lawyer, and he was about to sue me because he did not succeed. But we gave him back his money to make him calm. And then he went and did bariatric surgery, came back to me after maybe 2 years and said, here I am. I didn't know him. He said, I am the lawyer whose case was failed ECG normal sinus rhythm. So يعني don't do any obese patient, otherwise you regret yourself or pay him back.
بس كومنت على سؤال دكتور يحيى. I do think you mean the new drugs for weight reduction. So we have a study on the semaglutide in the heart failure with preserved ejection fraction. Actually, it improved the composite outcomes of heart failure hospitalization. And one of the endpoints of this study, or it's not the endpoint, it was an observation in this study, in these patients, the incidence of atrial fibrillation is slightly less with the semaglutide for the weight reduction in comparison to the other patients without. So it might be one rule of these drugs that it can decrease the body weight and then decrease the atrial fibrillation incidence and prevalence. We have also another paper recently published on the sodium glucose co-transporter 2 inhibitors that it decreased the incidence of atrial fibrillation even in the patients with heart failure. So probably these drugs will play a role together with AFib ablation in our patients. For the second question.
For the second question, obstructive sleep apnea, by a way or another, it is also related to obesity. And it is properly investigated by the sleep lab. And from our knowledge, from our colleagues in the chest department, that it is the best treatment for it is the continuous pressure airway CPAP, with the CPAP. So it is the best treatment for obstructive sleep apnea, and it improves the patients markedly until also the risk factors, including the obesity, is treated.
You send all patients, all certain body mass index, or okay, or those who are snoring?
Yes. It depends. It depends on part of it depends on the history, because the history of the spouse, because it's very important to ask the wife or the partner whether what is happening during sleep, and because it is not witnessed. So the sleep lab is very important in this situation. Yes.
The reason I ask this because in my clinical practice, we do see patients who turn to be obstructive sleep apnea. They don't have the classical profile of short neck, obese, and sometimes not everybody is married, and even if they are married, most people they sleep in different rooms. So sometimes the history is not as useful.
Yes.
But I think high index of suspicion for obstructive sleep apnea should be the rule.
So do you have any question from the floor? So we'll go to the next speaker.
Okay. It's my pleasure to present the princess of electrophysiology in Egypt, Dr. Rania Samir. She's now an eminent consultant electrophysiology in Africa and the Middle East. She's a professor of cardiology at Ain Shams University, and she will present to us how she does point-by-point ablation and the recent technological advances. Rania.
Thank you, Dr. Mervat, for the elegant presentation of me. You're my mentor, you and Dr. Wagdi. I'm so proud to be among my colleagues and my professors here. Okay, my talk today, I'll try to be strict with the time. I know I'm not. Point-by-point ablation, recent technological advances. As we all know that atrial fibrillation is the commonest arrhythmia encountered in clinical practice, with a prevalence of 0.4% in general population. And this prevalence increases with age, reaching up to 10% beyond the age of 80. And it represents a major risk factor for morbidity and mortality, mainly related to embolic events and heart failure. Over the last 3 decades, catheter ablation of atrial fibrillation has evolved into a highly effective treatment for rhythm control of atrial fibrillation. And pulmonary vein isolation remains the cornerstone of atrial fibrillation ablation, even in patients with persistent and long-standing persistent atrial fibrillation. And pulmonary vein ectomy is still the most prevalent trigger of atrial fibrillation. Many randomized clinical trials compared catheter ablation to antiarrhythmic drugs for rhythm control, and of course, it proved superiority of a catheter ablation over antiarrhythmic drugs. That's why in the most recent guidelines guidelines that was published back in 2020. Atrial fibrillation ablation, most specifically pulmonary vein isolation, was recommended for rhythm control in patients with paroxysmal atrial fibrillation or patients with persistent atrial fibrillation, whether there is or there is not risk factors of AF recurrence in case of failure or intolerance to one antiarrhythmic drug. And despite the satisfactory first-year results or outcomes of atrial fibrillation ablation reaching up to 70% in early studies, still the long-term outcomes of a catheter ablation of atrial fibrillation are still poor. In a study that evaluated the 10-year clinical outcomes of pulmonary vein isolation in patients with paroxysmal atrial fibrillation who were ablated between the year of 2003 and 2004, it showed that the 10 years outcomes or success rate of pulmonary vein isolation is very poor. It reaches around 33%, and it can go up to 63% after multiple procedures. A similar study that also evaluated long-term outcomes of long-standing persistent atrial fibrillation ablation showed that the long-term outcome after a follow-up of up to 59 months showed that success rate reaches down to 40%, ranges from 40% to 60% after a single procedure, and after multiple procedures it can reach up to 70% in some studies, despite the type of ablation protocol. Sorry. Sorry. So that's why هو فين البوينت؟ أول حاجة خالص؟ أوكي. بس أنا مش شايفاه. عشان لو حبيت أشاور. أوكي. That's why the recent technological and technical improvements in catheter ablation that were very impressive over the past few years have been targeting something important. It's targeting improving the long-term success and reducing the recurrence rate, especially in patients with persistent atrial fibrillation, without affecting the safety profile of the procedure with lower complication rate. Many studies have been conducted trying to understand why atrial fibrillation recurs after catheter ablation or after PV isolation. And the majority of these studies, or all of these studies, showed that the main or the leading cause of AF recurrence after pulmonary vein isolation is recovery of the pulmonary vein conduction or a pulmonary vein reconnection, reaching up to 17% in some studies in repeat procedures. Both in patients of paroxysmal atrial fibrillation and persistent atrial fibrillation. That's why the recent advances in catheter ablation or pulmonary vein isolation were targeting durable and effective transmural lesions to have durable pulmonary vein isolation. In point-by-point ablation, that was achieved by introduction of contact force technology, which was a breakthrough in the field of pulmonary vein isolation. Also, the introduction of protective lesion indices and high power, short duration, very high power, short duration ablation techniques, and also the introduction of single shot ablations, including cryoablation and laser and RF and PFA, which is beyond the scope of our talk. In persistent atrial fibrillation, the situation is a little bit different due to the complex nature of the mechanism, of the underlying mechanism of persistent atrial fibrillation. So it's not centered only around achieving a durable pulmonary vein isolation. We have to look for other novel targets for ablation in patients with persistent atrial fibrillation, and recent advances started to target or started to tackle this issue. The introduction of, as I said before, the introduction of contact force technology into the field of RF ablation or pulmonary vein isolation has caused a leap in the RF ablation of atrial fibrillation ablation, because it allowed the operators to create more consistent energy delivery. But studies that compared contact force catheters to non-contact force catheters didn't show change or in behind the AF recurrence or the long-term success rate. But the introduction of lesion indices or the use of lesion indices, which incorporate not only the contact force, but duration and stability and power for every lesion delivered, showed more reliability in predicting the durability and transmurality of RF lesions compared to contact force alone or FTI alone. And in a study evaluating the ablation index in patients with paroxysmal atrial fibrillation using an ablation index of, using an ablation index of 55 anteriorly and at the roof and 400 posteriorly and inferiorly, showed a significant reduction in pulmonary vein reconnection in repeat procedures, and also associated with a high 1-year success rate reaching up to 80%. In an effort to create transmural lesions while avoiding collateral damage, there was an introduction of the recent technology of using high power, short duration, very high power, short duration during ablation or performing pulmonary vein isolation. And the concept behind the use of high power, short duration, very high power, short duration is that it plays on the fact or the biophysics of the RF energy or the tissue damage or the creation of ablation lesions by increasing the resistive heat lesion or heat, increasing the lesions created by resistive heat, creating larger lesions, superficial endocardial lesions, and decreasing the conductive heat that is responsible for the depth of the lesion. By using high power for a short duration, we create a wide endocardial lesions, shallow lesions, not deep, because we limit the duration of the RF energy, and we limit also in very high power short duration, we limit the irrigation flow. So we create wider lesion without gaps, shallow lesions without complication, without increasing the complication rate. In a recent study published that evaluated the high power short duration protocol using the closed protocol, comparing patients undergoing high power short duration pulmonary vein isolation and conventional ablation using low power and normal duration, showed that there was significant reduction in the procedure time, and also a significant reduction in RF time with high energy people, with high energy group, without affecting the safety profile or increasing the complication rate. There was no significant difference in the complication rate between both groups. And the success rate after 6 months was comparable between two groups, which was quite high with 80%. And the recurrence rate was quite low. In using very high power in short duration, very high power is reaching up to 90 watts for 4 seconds for very short duration. There was development of a new catheter which is capable of delivering very high energy, like 90 watts, which is the Q-dot catheter. I'm not going to go into details into the structure of this catheter, but this catheter was capable of delivering this high energy and in a temperature control mode by continuous monitoring of tissue temperature all the time to avoid char formation and to avoid steam pop formation. And it is equipped with improved irrigation system with low irrigation flow rate, and equipped with a specific RF generator capable of ramping up the power up to 100 watts. And if we look at this heart specimen, we can see that very high energy, is associated with the formation of wide superficial endocardial lesions with no gaps. It's compared to lesions that are created using the standard technique. We can see deep lesions that with very visible gaps between the lesions, while the lesions created by the very high energy 90 watt shallow endocardial lesions, wide lesions with no gaps in between. Of course, this will affect the success rate and long-term success and recurrence rate of the atrial fibrillation. And in a study that was published in this year, evaluating very high power duration using the very close protocol, comparing two groups of patients. Patients who underwent pulmonary vein isolation using very high power, 90 watt for 4 seconds, and other patients using high power, only the high power, with the target ablation index of 55 anteriorly, 550 anteriorly and 400 posteriorly, and showed that there was significant reduction in procedural time with very high power. The procedure can take only 1 hour, with also significant reduction in radiofrequency time. And this didn't impact the complication rate. There was no significant difference between both groups as regards the complication rate. There was significantly low level of severe adverse effects and minor complications. And at the same time, the 1 year survival, arrhythmia-free survival rate is in both groups was comparable, reaching up to 80%, and on repeat procedure, the percentage of durable PVIs was quite significantly higher among patients with very high power short duration compared to high power short duration. I'll have just 1 minute talking about persistent atrial fibrillation, using trying the new technologies in point-by-point ablation, trying to find new target for ablation for persistent atrial fibrillation. As we all know, the STAR AFib trial showed that pulmonary vein isolation is currently the only acceptable method for ablation for persistent atrial fibrillation, and other methods showed failure. But recent investigators showed that we can use other novel methods for ablation of persistent atrial fibrillation to increase the long-term outcome, like ablating or low voltage areas in the left atrium, whether isolating them or connecting to an anatomical structure. In a recent, but the results of low voltage area ablation were quite controversial. In a major study that was published this year, the DECAF-2 trial, which is a randomized clinical trial published by Marouche et al., showed that there was no significant difference in the outcomes in 1 year outcome in PVI alone compared with PVI plus low voltage area ablation guided by MRI. But in a meta-analysis that incorporated 4 randomized clinical trials, used low voltage ablation in addition to pulmonary vein isolation, showed different results. Showed that low voltage area ablation in persistent atrial fibrillation shows significant reduction in AF recurrence and improvement in long-term outcome, but this didn't show in paroxysmal atrial fibrillation ablation patients. Also, there was also the introduction of the ablation of posterior wall isolation. The results of a major study that compared pulmonary vein isolation alone to posterior wall isolation showed no difference in long-term outcomes. In conclusion, it has been almost 30 years since the pioneering of first application of atrial fibrillation catheter ablation. Since then, there was substantial technical and technological advances have been introduced to improve the long-term outcomes of atrial fibrillation ablation. The continuous implementation of new technologies and ablation strategies have contributed to make the ablation procedure more faster, more effective, and safer. The long-term maintenance of sinus rhythm in persistent atrial fibrillation is quite challenging and needs further improvement in ablation techniques. A wide variety of new development technologies, including technologies designed to achieve more durable lesions, also those to map novel targets for adjuvant ablation beyond pulmonary vein isolation, may help to improve outcomes in ablation of persistent atrial fibrillation. Thank you. It was a long topic to tackle, 15 minutes.
Is it better than cryoballoon, the new method of high pressure?
Excuse me?
The new method of high pressure ablation better than cryoballoon ablation, or the same result?
Well, it's not. We cannot say it's more effective. In studies that compared cryoablation to catheter ablation of atrial fibrillation ablation, the results were quite comparable between both groups. But the patient selection really that determines, or the patient type that determines which type of energy you can use for AFib ablation.
I was revising this in my presentation, which will be at 2 o'clock. And when they compared the Arctec, the old version, to the
Second
RF
generation.
ablation, same.
Ul-
But
ultra low.
when
RF
they
balloon.
compared the Smart Touch to the recent cryo balloon, Smart Touch win. Yes. So this I'm going to present in 2 o'clock.
Rania, what about the multi-electrode casters recent innovation في التولز واعتقد ان دي يعني may be very beneficial especially if you use RF current it's very unpredictable to the depths of the lesion and the width of the lesion. That's why many cases of RF ablation have a recurrence and gaps that lead to atrial fibrillation, atrial flutter, atrial tachycardia. That's why the new energy may be very promising. But uses of multi-electrode caster, platinum والdiamond, is very beneficial for persistent atrial fibrillation because you can map the substrate, atrial substrate, in different direction. So it get a much durable lesion. In same time, bi-direction, but get a mapping in different wave fronts of atrial fibrillation. So the success rate may be better in using the multi-electrode caster, penta-array and different.
Yes.
So in the next presentation, we'll hear about the single shot ablation, the cryo and the Farapulse and the new technologies. But I have a single comment on the previous presentation that up to this point, the pulmonary vein isolation is the key in AFib ablation, whether
Yes.
persistent or
Or
paroxysmal.
paroxysmal, it's the key.
And we don't have any clue that any other additional points
Till
may
now.
improve.
Till now, most of the studies, even the recent technology, when they suggested we can ablate low voltage areas ablation, there is controversy in the results between the studies. We are waiting for the results of a study known as suppressed atrial fibrillation to evaluate the low voltage area and persistent atrial fibrillation. In posterior wall isolation showed disappointing results. Still now, pulmonary vein isolation is the key point. That's why we're looking for durable pulmonary vein isolation as much as we can.
So, and the pressure monitoring, either the Smart Touch or the Tacticas is the pioneer in this field.
You cannot do pulmonary vein isolation now without contact force.
Okay, thank you,
without
Dr. Rania,
ablation.
for this
Thank you.
excellent presentation. Again, probably same theme of questions. What do you do with a specific group of patients with heart failure? Because I believe whether they are paroxysmal or persistent, they do have, when you do a voltage map, they do have a lot of scarring in the atrial wall.
Yes.
And smaller study in the past demonstrated that pulmonary vein isolation alone is not that effective. And when you look at the data of the Castle AF, also the RAFT and the ATAC, the decision what to do with the ablation was left to the discretion of the operator.
Yes.
So in such patient, what do you do with AF patient, let's say, who has persistent AFib? Do you do BVI only or you do more?
Okay. Of course, it depends on the patient. I'll do voltage map first, and I'll see if there is scarring, extensive scarring of the left atrium, most particularly the posterior wall. The literature says that I have to go and do PVI isolation and go out for the first procedure. But in a country like ours, on an economic status, if I find low voltage areas, I might go for low voltage area ablation or maybe posterior wall isolation, despite the disappointing results of posterior wall isolation. If I had, if I have an vein of Marshall, if I alcohol ablation, I might do it. If I have this technology here, I might do it.
I'll tell you what's my personal experience. Patient who has heart failure, we don't do BVI only. We always do line.
Yes. You have
All
to do
patients.
more. You have to do more. Yes.
Yeah.
Yes. Yes.
Yes. Thank you, Rania. We'll go for the next speaker for the sake of time. It's my pleasure to introduce my friend and colleague, Dr. Ahmed Tahir from the Critical Care Medicine, with the presentation under the title of What's New in the Single Shot Ablation. Dr. Ahmed.
Thank you very much, Dr. Haitham, for the invitation and introduction. My pleasure and honor to be among the distinguished leaders of Ain Shams University. Dr. Yahya, pleasure to have you in Egypt. Dear guests, I think I'll try to be very focused. My talk is about the new advances in single-shot ablation. Just a quick note, show of hand, is there anyone who's not Arab speaking? Is it okay? Yeah, because I have too many details in the presentation and I think it might be better absorbed if I say it in natural language. Okay. Okay, ميزة ان انت تبقى تالت محاضر في presentation كلها consistent ان I can skip the introduction about indication for AF ablation. I'll go directly to what I need to talk. Point by point versus single shot. زي ما دكتور رانيا قالت من شوية البوينت باي بوينت كان هو الستاندرد بتاع AF ablation لفترة. طبعا بعد كده ظهر السنجل شوت كرايوبالون تقريبا في 2010 بدات الايرلي ستاديز بتاعتها ميدترونيك وايه اللي يخلينا نتحرك ناحيه سنجل شوت فيرسس بوينت باي بوينت ابليشن. اكشلي مزايا البوينت باي بوينت هي عيوب السنجل شوت اند فايس فيرسا وتقدر تقلبهم زي ما انت شايف. بوينت باي بوينت definitely it is the standard, it is the very flexible, adjust to different anatomy. الليجن creation is very controllable and precisable وفي نفس الوقت اقدر integrated مع 3D system ده الستاندرد بتاعها وتقدر تابليت targets other than pulmonary veins. ده اللي اقدر اعمله بالبوينت باي بوينت. single shot application on the other hand ما بتقدرش تعمل الكلام دوت at least to a great extent. في advances في الموضوع ده ولكن القاعده ان هي ما تقدرش تعمله. On the other hand the single shot application are easier to learn. بتحقق لك التارجت اللي احنا اتكلمنا عليه في الاول اللي هو البالمونري فين ايزوليشن بسرعه and dwelling time قليل. سايد افكتس اقل والاهم من كل الكلام ده البروسيجر ديوريشن والليرنينج كيرف بتاع السنجل شوت ابلكيشن اقصر وبالتالي هي اسهل تو بيك اب اند تو ادوبت. طيب accordingly احنا عندنا اوبشنز كتيره جدا في السنجل شوت pulmonary vein isolation المين توبيك بتاعنا ومن كتر التكنولوجي احنا ممكن for the sake of this presentation نقسمهم لتو كاتيجوريز كبار. حاجه اسمها بالون بيزد سنجل شوت ablation او tools و non balloon based single shot. في الاخر الاثنين بيعملوا multiple lesion او around the pulmonary vein بهدف الايزوليشن ولكن في حاجات بتبقى mounted على inflatable balloons وحاجات ثانيه ما بتبقاش كده. طيب ريفيو سريع حوالين اول تكنولوجيز هي الكرايو بالون ابليشن. دي حاجه ما هياش جديده ما هياش نوفل دي حاجه موجوده من زمان جدا. عندنا تو تكنولوجيز كبار فيها الاركتيك فرونت بالون كاثيتر بتاعت ميدترونيك والبولاركس بالون كاثيتر بتاع بوسطن. The principle of creating a circumferential lesion around the pulmonary vein is the same. في الحالتين بيبقى في nitric oxide gas injected inside the balloon بيؤدي إلى drop of temperature down to -80 degrees وده بيتسبب ice formation intra and extracellular and this process causes circumferential cell death around pulmonary vein and causes isolation. Definitely زي ما قلنا في كل المزايا بتاعتها اللي اتقالت كده easy fast and dwelling safety profile كويس جدا و at best it is not inferior to point by point application in terms of freedom of AF. Okay, so كل الهيد تو هيد ترايلز ما بين الاثنين although ان في ترايلز specifically highlighted edge for smart touch catheter بس there are other trials who highlighted ان هما الاثنين effective. الاثنين بيحتاجوا sealing and this is the technical issue with them and some anatomies are challenging than others so it is very useful but it's not a single solution for all PVI. Now the other types of balloon are the radio frequency balloon. نفس الكونسبت inflatable balloons لازم نعمل sealing around the pulmonary vein although to a lesser extent لكن ال creation of lesion بيبقى dependent على radio frequency application. أول example هي الهيليوستار catheter من بايسنس ويبستر. البرنسبل بتاعها إن هي بتديليفر unipolar catheter. خليني I hope I can yes. Okay, it delivers unipolar radio frequency energy through these electrodes اللي بيسميهم teardrop electrodes كلها unipolar وميزتها تحديدا ان هي فيها ديديكيتد مابينج كاثيتر، وبالتالي السيجنال مش ديجريدد بالابليشن، وتقدر تبقى تتشاف على 3 دي مابينج سيستم في الكارتون. So you can get a visualization as you ablate. Each single electrode is irrigated and controllable independent than the other electrode. So I can switch how much energy I need to dial on the posterior wall. I can stop ablation at certain electrode and continue in other. So it's very versatile and very malleable. The thing is that it can isolate pulmonary veins quickly. However, in the early reports in Radiance trial, the incidence of asymptomatic cerebral emboli and asymptomatic esophageal erythema were significantly high. I mean, the comment it is not that high. It's at the upper limit of what could be accepted, but it is high. Whether it has long-term implication or not, this is yet to be studied. The other radio frequency balloon and the other competitor is the Boston technology, the luminized RF balloon, and this is very interesting. The concept is the same. It is a balloon. It is radio frequency energy delivered over an electrode, and it has a very peculiar arrangement compared to the Heliostar. First, you have 12 equatorial electrodes and 6 forward-facing electrodes. You can apply unipolar or bipolar, and you have integrated microelectrodes for mapping. So you don't have a dedicated mapping catheter like the Thalasso and the Heliostar. The other thing is that you can use the forward-facing electrode to apply focal lesions. So it can be used for pulmonary vein isolation and theoretically, at least so far, for point-by-point ablation at the same time. It is also equipped with a real-life camera inside the balloon. So you can actually see the view inside the pulmonary vein, and this is what you see from the camera. It's important to be in contact, so this white line is the point of contact between the balloon and the wall, and this red area signifies poor contact in this region. So you can turn on ablation on the area where you can exactly see your contact with the tissue, and you can simultaneously monitor the formation of lesion. Now, in the early report as well, there is a very impressive, very high rate of pulmonary vein isolation, but again, it's very expensive technology and we need more studies about it. The last option, I was hesitant to include it, but it is there anyway, something called it's a hot balloon. It's almost so far exclusive to Japan, and it, again, occlusion balloon that uses thermal energy to create circumferential lesion, but the whole balloon is heated. It's not just RF delivery from surface electrode. The heating coils are present inside the balloon, and the balloon is filled with a mix of dye and saline, and that fluid becomes heated, and this heat is transferred to the tissue to create the circumferential region. Again, satisfactory early report, but no sufficient data, being only limited, having only a limited market release. Now, these are what we call the balloon-mounted technologies. The non-balloon catheters are, in my opinion, the future of AF ablation in the next years, okay? The classic example so far is the FARAPulse system from Boston Scientific. It's a whole new concept of energy. I'll give it a few times because I think it's important. It's pulsed field ablation through multi-electrode catheter, and different companies have different catheter for delivering this energy. In Boston, they use the basket catheter. I will show an example, and it's very selective cardiac myocyte. This is what makes it very exciting, so that the collateral damage is almost next to zero. It's very selective for cardiac tissue, and I'll show examples. And it's also recently has been integrated with 3D mapping system, the Rhythmia of Biosense. Interestingly, it requires very heavy sedation or GA because so far this is painful form of energy delivery and lesion creation. And I'll show you a quick video about the system. This is the catheter Boston uses for PFA. It's called the FARAWave catheter. It's a multi-electrode catheter. It has two configurations, something called basket configuration and flower configuration. This is the system. This is the catheter in flower configuration, and it'll show again in few seconds the basket. This is the system, very easy interface. You just select the energy you need to deliver and you press deliver. You don't need 3D mapping system to perform circumferential ablation, pulmonary vein isolation, just catheter in the left atrium. It needs to be precisely placed in the pulmonary veins, in the catheter and in the flow, and according to the recommendation of the company, you need 8 applications, 4 in each configuration. You start by the basket configuration. You apply 4 legions, 2 in first orientation, like this. You apply 2 legions, and then you rotate the catheter almost 36 degrees, and you apply another 2 legions. Then you put the catheter in flower orientation. So this is the first orientation, the basket. Then you change it to flower orientation. 2 application, rotation, another 2 application, and this vein is isolated. This is not obviously single shot. However, the isolation usually occurs with the first application. All subsequent lesions are required for the durability of isolation rather than together. This is what makes it interesting. When you study, it's very selective for cardiac myocyte to the extent that the blood vessels and nerve inside the wall of the left atriums are intact, or at least this is what we know so far about it. And consequently, extra cardiac tissues like the phrenic nerve and the esophagus are again spared. So this is what I want to talk about, pulsed field ablation. It's a very different form of energy. RF or DC current are delivered in biphasic, usually mean, and this is called alteration of the polarity of cell membrane, which eventually causes a creation of water holes. And these water holes, when you reach certain number, they call autolysis or apoptosis of the cells and permanent cell death. You need to titrate the energy to land in the sweet spot between forming, this is what you don't want to have. You don't want to apply too much energy to create thermal injury, and you don't want it too low to be a reversible lesion. You need to land in this sweet spot where you have a non-thermal, durable electroporation. It's very safe, it's very attractive, it has a large safety margin. It's very selective in terms of tissue, and you can see this. This is the energy you need to cause an irreversible electroporation for myocardium from animal study. And when you compare it to the energy required for collateral tissue, it's almost 3 or 4 times. This is what makes it very selective for cardiac myocytes, and the incidence of collateral damage accordingly is very low. Even in animal study, when they went extensively and opposed the esophagus to the left atrium and created huge lesion. This is the esophagus after, this is the esophagus after pulmonary vein, completely intact despite deliberate high voltage energy. And this is the esophagus in animal studies, how it is with radio frequency energy. Again, the same thing. I just need 2 minutes and very quickly. Again, it's attractive when you studied the posterior wall and the esophageal edema after cryo or point-by-point ablation. No enhancement in the esophagus as opposed to that with point-by-point or balloon cryo, even cryo. Again, because the mode of energy is not thermal, so the cell death is not inflammatory, and accordingly, the extracellular structure of the tissue is preserved and the incidence of fibrosis is low. This is why the left atrial transport function is not affected with pulsed field ablation, and there is almost no incidence of pulmonary vein stenosis after pulmonary vein, despite applications that could be inside the pulmonary vein themselves. This is why there are another catheters, another company started to pick up the concept and apply pulsed field ablation on different catheter. Medtronic acquired or revived the PVAC catheter, and they just published their first studies on the PVAC, on pulsed field ablation. Again, very attractive, has the same limitation of GA. Biosense Webster also are joining the race, and they have their own platform for delivering pulsed field ablation. And again, they revived the Inmar catheter that was stopped almost in 2013 to 2018 and use it as a platform for delivery of the pulsed field ablation. And they took the advantage of integrating it with CARTO3 system. Now, this is a different concept. This is different energy. This is not the pulsed field ablation. This is a new tool for non-balloon pulmonary vein isolation, single shot, which is the ultra-low temperature catheter. Again, it's an extension of the cryo concept, but with a different delivery. The thing is that you use different catheter to deliver nitric oxide, but the temperature drops to very low limits, down to minus 190, you can pre-shape the catheter with nitinol stylet, so you can actually achieve CTI single shot ablation. So it's pre-shaped to do that. But the other hand, if you're planning to do pulmonary vein isolation, you need to cool the esophagus because of the temperatures. So you have a dedicated warming balloon that needs to be placed in the esophagus to prevent esophageal injury. Again, globe catheter, something that was pulled from the past, again, is being investigated for cryoballoon, for PFA. So my take-home message is that single-shot PVI allows for standardized PVI in relatively short procedure time, and single-shot PVI using pulsed field ablation catheter offers similar efficacy, at least from the early studies so far, to other energy forms, but with better safety profiling. This is the main selling point of pulsed field ablation. It is the safety. And since pulmonary vein isolation is the standard approach, and this is what my colleagues in previous presentation, they've all acknowledged, it is the standard approach for first AF ablation procedure, single shot PVI tool is a reasonable forced ablation option. Thank you very much. All companies will say that is single-use catheters. This is, I mean, we can see about that later on. But all of them are single-use, definitely. Yeah.
Thank you, Ahmed, for the
Thank you, Dr.
very advanced talk.
Thank you.
My question, you know, sometimes Young deliver elasticasters that map electrophysiological and in the same time ablate.
Yes.
So it's called Frontier system at that time. What is the best new version for mapping and ablation same time? I think single shot maybe the new version, the best new version for this.
Yes. So the first comment you highlighted, the lasso catheter for mapping and ablation. Actually, this is a concept has been for a while. Medtronic had something called the PVAC catheter, pulmonary vein ablation catheter, in the past, and used to have platinum, then gold, then I don't know, they have diamond versions of it right now. And Biosense had the NMARC catheter, which is an exact development of lasso catheter, just with wider electrodes that allows for both monitoring and ablation. Now, the catheter right now for single shots, the best we have so far, or at least the most studied one we have so far, is the FARAWAVE catheter from Boston, integrated with the FARAPulse system. It's specific, it's not circular, it's not lasso, it's not open-end catheter, it is closed-end catheter, but has, I think, 4 splines. 5 splines, okay, my mistake. So it has 5 splines that can be configured in 2 shapes. One of them is the flower and one of them is the basket, and you need to interchange between them to isolate. I think Dr. Yahya already has a very good experience with ablation. I know from previous talk that he used it, and I'm interested to know your experience with it.
As you said, thank you, Dr. Ahmed. This is a very nice presentation. I personally enjoyed it.
Thank you.
I think FARAPulse, or the pulse field concept, is a new concept in ablation. It's, I would say, the holy grail of AF ablation or pulmonary vein insulation. I hope we will have a long-term study. We do have enough data so far to show that the success rate in patient with paroxysmal atrial fibrillation is about 82%. In patient with persistent or even long-standing persistent AFib, it's about 72, sometimes 60 in certain patient population. If even you say 60, 62 in long-standing persistent, I think this is a good result. I think this technology is here to stay, and it will replace most of the other single-shot technologies.
Yeah. And I think they are trying to integrate it in a focal point by point as well.
Okay, so I think it will replace most of the single-shot, but the RF will remain for certain cases. We do have the first version of the catheter. We don't have actually the integration with Rhythmia yet, but we will have it soon, and it will be integrated not only with Rhythmia, with all other 3D mapping system. And I believe it made the procedure so easy, very safe. As you mentioned, the incidence of pulmonary vein stenosis. As far as I know, there is no reported case of pulmonary vein stenosis. The esophageal injury so far, with thousands of patients, we have no single report of esophageal injury. However, when it comes to phrenic nerve, there is report, maybe 1 in 1,000 or a couple of thousand, which is very rare if you compare it with the cryoballoon. So our initial experience, so we had it now for more than 1 year, and we had more than 50 cases done by myself. I think it's very simple. We never had any trouble or even minor complication with it, and the result, patients are very satisfied. And what I like more, it made the procedure less than 1 hour, even if you do it under GA from skin to skin, including the intubation. 1 hour, the patient will be outside the lab. You can do 2 or 3 and another VT after that in 1 day. And the second thing is that the patient experience is remarkable. After RF ablation or even cryoballoon, the patients tend to feel some pain, pleuritic type, or discomfort. However, in this type of technology, because there is no much inflammation in the wall of the left atrium, it's only electroporation, so your effect is at the cellular level. So I think it's very good technology. We have the first version, and in a few years' time, we will have more and more from different company, and I think this is the future.
Thank you, Dr. Yahya. Not yet. So for the sake of time, thank you, Ahmed, for the very nice presentation. I will go to the last speaker in the session, but not least, Dr. Muhammad Hajiri. He's my colleague from Ain Shams University, actually. We're in the same class, but he looks older than me. He is board certified from the US, and now he's working in Amman in Abdali Medical Center. He's a consultant of interventional electrophysiology. Dr. Hajiri.
Thank you. Thank you very much. I'm very excited in being in Egypt after 20 years. Thank you. I left as a medical student 20 years ago in 2002, and now I'm back as a consultant speaking here in one of the conferences. So my massive appreciation for Egypt and for Egyptians for all their support and for making me a doctor. So after Egypt, I went to the US, and I recently moved back to Jordan. I'm going to talk to you about burning that fib. And I think one of your biomedical engineers, Khalid, where's Khalid? Khalid works with me here, so most of these... Exactly, he's a double agent. All right, so I like to present things like a little bit more interactive so that people can feel the nice thing about EP. 32-year-old man with palpitations that is persistent, symptomatic for the past few days. Okay, so this is a hall filled with EPs. Everybody knows this is AFib. This is who came in with this. Okay, so what do? I'm just curious to know what our colleagues will see. Would we cardiovert right away? Would we amio, conquer, Eliquis? This is a Jordanian thing, which I'm trying to oppose. And IV heparin TE cardioversion the next morning, or TE cardioversion right away. We can either make votes, or I can just tell you what I did. What I... You can go for the time. Say again? You can go for the sake of time. Yes, okay. So I usually would go with IV heparin. How do we go back? There you go. We go with IV heparin TE cardioversion because we don't know how long that's been going on. And this is one of the things. Patient back 1 month later, the AFib tends to come back. Now what do? Antiarrhythmics, FLEC, amio, DIG, and amlodipine. And these are the things, if it's back again, what do? Amio, dronedarone, Concor plus amio, or we go for an ablation. Obviously, I'm EP, and we're going to go for ablation. Okay, one of the things I want to talk about here is and all my EP colleagues here know that when you have this very nice normal-looking tissue in the posterior wall and the anterior wall and the atrium, usually this is a healthier atrium, and this gives you better outcomes. So the talk today is multiple procedures. What do we do? And one of the points I want to try to tell you is that the best way to prevent multiple procedures is to do probably ablation early before we have all that scar tissue form, and before that we have a success rate for AFib ablation that is much lower than what it's supposed to be. This is one of our patients that we ended up ablating. And this is basically, this is a full fib ablation, and this is what we usually do. I wish there was a way we can pause it, but I guess there isn't. But when you look at the posterior wall with all that scar tissue here, a success rate for this guy is definitely different from the other one. And this is on very, very fast, it's much faster than what it's usually, but it was done in see, like 10 seconds. Fib ablations can be done in 10 seconds. We're actually very fast. We have to say, actually. This was a radio case. Exactly. So 42. This is a 42-year-old with mitral valve replacement, 10 years of AFib, declined ablation by 2 major facilities, and then she failed antiarrhythmic, including amiodarone. What would you do? Not care and just go and ablate? Amio, again, for 100 milligrams PO for lifelong, amio 200 milligrams lifelong, or flecainide. And we're going to go over all of that stuff. So we can see this massive, horrible scar in the anterior wall, and also the same thing in the posterior wall. And this is a case I don't think we did this with Khalid. I think we did this with Eid. But anyways, this is for those who are not really all EP, whatever you see, it is not the beautiful purple color that we're supposed to see. This patient, although she is young, but she has this massive scar. So we ended up ablating everywhere. Anterior wall, posterior wall, and trying to isolate the posterior wall. This patient is probably going to come back, and we'll go over quickly for some of the literature. Okay, so another very, very important thing is that whenever we have somebody who's had an open heart mitral valve replacement, is that to look into the right atrium, because you can find scar in the posterior wall in the right atrium, and sometimes a lot of the abnormalities are coming from the right atrium, not just from the left atrium, especially in patients these young and who've had some surgeries and ended up isolating the posterior wall. The patient was in an atrial attack and ended up terminating. So going over some of the guidelines for fib ablations, when to ablate, when not to ablate, going back to the very first point, probably the best way to prevent multiple ablations is to ablate early. And this is actually, at least in the ACC AHA guidelines, it is, in some situations, it is a class 1 indication to ablate early paroxysmal AFibs before they turn into something else. But I know that European societies, I guess it's still not a class 1. These are some of the things. For the interest of time, I'm just going to go a little faster. So this is some of the skeleton of how to approach different treatment for AFib. Medications, dofetilide, dronedarone, FLEC, propafenone, sotalol are still first-line treatment. Amiodarone is not a first-line treatment. I always tend to stress this a lot in my talks because I tend to see a lot of amiodarone being used, at least in Jordan. I don't know how it is in Egypt, but there's so much of it as a first line, and we don't want to do that. So class 1 indication, AF catheter ablation is useful in symptomatic paroxysmal AF refractory to intolerant to at least 1 class 1 or 3 antiarrhythmic. It's a class 1 indication. And class 2A is reasonable for those patients who are persistent AF intolerant to at least 1. Okay. Amio is a class 2A. It is reasonable if we want to convert. Same thing with propafenone and flecainide. Now let's take a look at this guy, 55-year-old with 10 years of AFib. This would be permanent. So most of the permanent AFibs, you do. But it's very young. I tend to ablate. Probably 3 times. We ablate. Correct. So I tend to be US trained. I'm Egyptian educated and US trained. So my training tends to take my better half, and yes, we do. It is correct. We do tend to ablate a lot in the US. Personally, I only ablate up to 3 times, and then after the 3 times, if that doesn't work, we go for an AV node ablation with a pacemaker. I think that's reasonable. I think we can agree on that tiny little bit. But look at this massive, horrible scar. Again, this is just horrible. Okay, this is an interesting study that was impact of early versus delayed atrial fibrillation catheter ablation on atrial arrhythmia recurrences. And it's interesting because it kind of gave us a timeline where when can we, like the timeline, how much time do we have when using antiarrhythmics before we go for ablation? And this was around a year. So if basically you use, if you ablate early for persistence and you wait for around a year versus, if you ablate early versus you try with different antiarrhythmics for 1 year, it makes no difference on outcomes. And the outcomes here were kind of low. They're like the success rate was around 56 to 57% in the study. And it did show that, but after the year, that kind of like drops dramatically. Okay, so for the sake of time, I only have 2 minutes, but ablations do work. A trial of antiarrhythmic then ablation is class 1. Reduce the use of amio, at least it's my personal opinion. It's a class 2A in AHA recommendations. Ablate early, don't wait until the scar tissue remodeling starts. From a practice standpoint, I do, as Dr. Mervat has mentioned, in the US, they tend to ablate a lot. I personally can ablate up to 2 or 3 times. If that doesn't work and the patient is still symptomatic, still has or low ejection fraction, then I tend to either do an AV node ablation with a CRTP if the EF is in the 40s, or a left bundle pacemaker if the ejection fraction is normal with an AV node ablation. Thank you very much.
Thank you very much, Dr. Muhammad. My question is, in case of multiple procedure and the late recurrence.
I'm sorry, in case
late
of
recurrence, late
Yes.
recurrence of AF.
Yes.
Usually late recurrence is not always reconnection. Maybe non-PV triggers, especially around superior vena cava or vena
Correct.
Marshall or roof. What's the best technique you use in those patients?
So in those patients, it's a great question, because in those patients, usually what I do is a PVI for a very first time. But once you recur, I just go after that posterior wall. We go isolate the posterior wall completely with a roof and a posterior line. And then sometimes I do isolate on the right side as well, but most of the time, either that, and then I just go after we do a voltage map, and then we go after anything that looks like an isthmus or looks like anything that's abnormal.
Do you use specific tools, specific sort of caster for those patients?
I'm a very RF person.
Yeah.
So almost, even when I was in the US, almost like 100%, 90% of my cases, I would do them with RF. Sometimes I would do the cryo balloon. I am yet to try the PFA, although Biotronic Biosense will not be happy to hear that.
Do you have any experience on hybrid therapy for those surgical with cardiac?
You mean Maze?
Vest ECG mapping from outside with the endocardial mapping?
No, I don't actually. So with the surgical, you mean like a Maze procedure? Or?
Yes.
Yeah, of course. So if I have a patient who has AFib, who's going on for CABG, then the first thing we tell the surgeon, Maze plus left atrial appendage ligation. And that's the best way probably to treat these patients. The Maze, as you know, the data doesn't really support it very well. They tend to come back. But if they do come back after the Maze, then I would go an endocardial ablation, and I would treat it as a persistent AFib. So I would just go isolate that posterior wall and just go crazy.
Thank you very much, Dr. Muhammad, for this presentation. I just want to remind myself and everybody that the decision to make it permanent is actually not related to the duration. It's related to the decision of mainly of the patient with contribution from the treating physician, and it's always reversible. So when you ask, is this permanent or not permanent, I think the patient has to decide and the treating physician has to decide. Second, I think such cases doing 5 or 6 ablation is nonsense when it comes to me. Whether it's done in Marsh or
I agree.
US or anywhere, that's not acceptable. I think there is always a very good surgical technique, mini maze, standalone surgical maze. Now it has a very excellent safety profile and excellent long-term outcome. So
And it
in such
takes,
cases, if the patient is very symptomatic, still willing to pursue sinus rhythm, I think this is the time to refer patient for standalone mini maze procedure.
Thank you.
Thank you, Dr. Yahya. Thank you, Hajiri. It was my pleasure to see you once more.
Thank you very much.
So for the sake of time, we'll conclude this session and I will invite the next chairperson to be on the chair. Thank you very much.